Hello, here's the clinical pharmacist Rose. How can I help you?
Hello, Rose. This is Amanda. I'm an internal medicine resident. I have a discussion tomorrow about peritonitis, and I don't have any information about the topic. So, could you help me, please?
Yes, of course, I would be happy to help. Oh, by the way, peritonitis is a very interesting topic because I've read some study which demonstrate a prevalence of 7%.
Oh, that's great. But first, what is peritonitis?
Well, peritonitis is an inflammation of the peritoneum, which is the membrane that lines the part of the abdominal cavity, as it results from infection or chemical inflammation within the peritoneal cavity. And it can be classified as primary or secondary peritonitis.
So, I've mentioned two types of peritonitis. Can you please explain the difference between the primary and the secondary?
Oh, sure. Well, first of all, primary peritonitis is a subcutaneous bacterial infection in the peritoneal cavity in the absence of the intra-abdominal pathology, often via homogeneous or lymphogenous spread, and it's most frequently identified in adults with cirrhosis or ascites. While the secondary peritonitis can result from contamination of the peritoneum with the gastrointestinal microorganism as a result of the loss of the mucosal barrier integrity.
Oh yeah, I just remembered. Yesterday, I saw a case of patient who was in peritoneal dialysis and then unfortunately he got an infection. So, does all patients on peritoneal dialysis have a high risk to be infected?
Well, actually, yes. It's one of the risk factors of the primary peritonitis, which also include liver disease or cirrhosis, accumulation of the fluid in the abdomen or ascites, and weakened immune system.
Is this also apply for the secondary type?
Well, no, actually there is a difference between the risk factor of the other type, which include appendicitis, perforated peptic ulcer, inflammatory bowel disease, and abdominal trauma.
Yeah, great, I got it. But I have another question. Does all patients with primary and secondary have the same clinical presentation?
No, primary and secondary peritonitis are different from each other regarding to the clinical presentation. Primary peritonitis patients will suffer from nausea, vomiting, diarrhea, abdominal tenderness, normal temperature or mildly elevated, bowel sounds are hypoactive, and sometimes a cloudy dialysate fluid found with the peritoneal dialysis. While a patient with secondary peritonitis will experience abdominal pain with nausea and vomiting, and decreased urine output, tachycardia and tachypnea. Unlike the primary peritonitis, patient temperature will significantly increase from 37.7 to 38.8 in the first few hours and continue to rise for several hours. Patient may also suffer from hypotension and shock.
So, you say that they are different from each other in the clinical presentation and the risk factors. So, the causative microorganisms must be different as well. Is that right?
Yes, it actually differs from type to another. For example, with the primary peritonitis, more than 92% of all cases of subcutaneous bacterial peritonitis are monomicrobial. In cirrhotic patient, E. coli is the most common pathogen, followed by Klebsiella pneumonia, then Streptococcus pneumonia. But in case with peritoneal dialysis, gram-positive bacteria Staphylococcus epidermidis is the most common causative organism, followed by Staphylococcus aureus and Streptococcus species. While with the secondary peritonitis, there will be presence of the intra-abdominal pathogen and polymicrobial infection. Mixed flora contain both aerobic, like E. coli, and anaerobic, like Bacteroides fragilis bacteria.
Yeah, I can see.
Oh, sorry, did you get confused?
Oh, not really. I'm searching about the diagnosis of each type.
Oh, that's great. Can you tell me what did you find out?
Yes, of course. So I found out that the patient with primary peritonitis will have Mildly elevated white blood cells count. Ascitic fluid usually contains more than 250 leukocytes per cubic milliliters. Gram stain is negative. Other diagnostic tests may involve culture of peritoneal dialysate or ascitic fluid should be positive. While the patient with secondary peritonitis will have leukocytosis range from 15,000 to 20,000 white blood cells per cubic millimeter, elevated hematocrit and blood urea nitrogen as a result of dehydration. Patients will suffer from early alkalosis due to hyperventilation and vomiting, 2 acidosis. The physical examination will show some abnormalities such as involuntary abdominal guarding changing to involuntary guarding, abdominal tenderness and distension, faint bowel sound.
That's great. Let me tell you now about the treatment.
Okay, tell me about the primary first.
When intra-abdominal infection is suspected, empiric therapy should be initiated as soon as possible to enhance the patient's chance of survival. Antibiotics are prescribed to control the infection. Intravenous therapy is used to restore hydration. Antibiotics should not be started until ascitic fluid has been obtained for culture.
Oh, good. Okay, what about the secondary peritonitis?
Well, the treatment of the secondary peritonitis is divided into two types: pharmacological and non-pharmacological treatment. First of all, for non-pharmacological treatment, we should use fluid repletion to correct dehydration and maintaining adequate cardiac output, tissue perfusion, and correction of acidosis. And in patients with significant blood loss, blood transfusion should be done. We also should use painkiller to manage pain, and use internal or parenteral nutrition to improve the immune function and wound healing. And I should also mention that it can be treated by surgery as well. And for the pharmacological treatment, the antibiotic should cover gram-negative and anaerobe bacteria.
Oh, like beta-lactamase inhibitors and carbapenems or fluoroquinolones?
Oh yes, exactly. For mild to moderate community acquired, we can use monotherapy as ertapenem, cefotoxin, or tigecycline, or combination therapy as metronidazole plus cephalosporin or fluoroquinolone. For severe community acquired, we can use monotherapy as piperacillin tazobactam or meropenem, the last line agent, or combination as metronidazole with third or fourth generation cephalosporin, or ciprofloxacin, or levofloxacin, or aminoglycoside. Oh, there's one thing to remember. The antimicrobial therapy should be limited to 4 to 7 days depending on the patient's clinical response to therapy.
Great, I got it. So, can you tell me about the major antibiotic side effects?
Oh, sure, yes. Well, their common side effects include gastrointestinal effect, such as nausea, vomiting, and diarrhea, as well as headache and insomnia. And about the major side effect, FDA wrote, an FDA safety review has shown that fluoroquinolones, when used internal or parenteral, such as tablets, capsule, or injection, are associated with potential serious side effects that can occur together. These side effects can involve the tendons, muscles, joints, nerves, and central nervous system.
Okay, that's great. So, what about cephalosporins?
Well, cephalosporin can cause a few side effects. Common side effects involve mainly the digestive system, diarrhea, mild stomach cramp or upset, nausea, and vomiting. Cephalosporin can also cause overgrowth of fungus that normally present in the body. Hepatic toxicity occurs rarely and usually as elevation in the transaminase level. More serious but infrequent reactions include black tarry stool, painful or difficult urination, antibiotic-induced colitis, severe watery diarrhea, severe stomach cramp, fever, and weakness.
Okay, what about metronidazole?
The common side effects of metronidazole are abdominal or stomach cramp, dizziness, feeling of constant movement of self or surroundings, heartburn, sensation of spinning, trouble sleeping, weight loss, and the major one are blindness, decreased vision, and central nervous system side effects.
Okay, can you tell me about carbaminoms?
Their side effects include nausea, vomiting, diarrhea, constipation, headache, redness, or swelling at the injection site.
Well, that's very good. I have another question. How can we monitor the patient in professional way?
First of all, you have to monitor the efficacy of the treatment by monitoring the patient response to medication, relief of symptoms, and improve patient quality of life. And you have also to monitor the toxicity, as I mentioned before, the side effects of the drugs, or if there is any drug-drug interaction with the other medications. Follow-up care depends on the cause of the intra-abdominal sepsis, and simple infections such as those caused by cholecystitis or appendicitis. Once the infection is cleared, no follow-up care is needed. However, in patients with perforated duodenal ulcer, chronic pancreatitis, or Crohn's disease, lifelong follow-up care is needed.
Are there any prophylaxis given to prevent spontaneous bacterial peritonitis?
Yes, there are some outpatient prophylaxis, although not routinely recommended. It has been shown to prevent subcutaneous bacterial peritonitis in the following high-risk group: patient with ascites admitted with acute GI bleeding, patient with ascitic fluid protein level of less than 1 gram per deciliter, patient with prior episode of subcutaneous bacterial peritonitis. The suggested regimen include norfloxacin 400 mg daily, ciprofloxacin 750 mg weekly, 5 doses of double-strength trimethoprim sulfamethoxazole per week.
Thanks, Rose. I'm really grateful to you for your help.
Oh, no need to mention. So, can you now summarize the difference between the two types of peritonitis?
Yeah, sure. So I'm gonna start with the general appearance of the patient. Patient with primary peritonitis may not be in acute distress, particularly patient with peritoneal dialysis, while patient with secondary type will be in acute distress. Okay, and regarding to the symptoms, patients with primary peritonitis may complain of nausea, vomiting, and abdominal tenderness, while the patient with secondary peritonitis may complain of nausea, vomiting, and generalized abdominal pain, and also may demonstrate abdominal guarding. And regarding to the signs, the temperature in patients with primary peritonitis may be only mildly elevated or not elevated in patients undergoing peritoneal dialysis. The bowel sounds are hypoactive. In cirrhotic patients may have worsening encephalopathy. The air may be cloudy, dialysate fluid with peritoneal dialysis. While in secondary type, tachypnea and tachycardia are present. The temperature is normal initially, and they may increase to 37.8 centigrade to 38.9 centigrade within the few first hours, and may continue to rise for the next several hours. The laboratory test. The white blood cells may be only mildly elevated in patients with primary peritonitis. Ascitic fluid usually contains more than 250 cubic millimeter leukocytes, and bacteria stain is negative. While the secondary peritonitis, the white blood cells is high with neutrophils and elevated percentage of immature neutrophils. The hematocrit and blood urea nitrogen increase because of dehydration. Hyperventilation and vomiting result in early alkalosis, which changes to acidosis and lactate. Other diagnostic tests in primary peritonitis is culture of peritoneal dialysate or ascitic fluid should be positive. While the other diagnostic tests for secondary peritonitis, abdominal radiograph may be useful because free air in the abdomen or distension of the small or large bowel is often evident.
Well, that's great. Now I think you're ready for your discussion tomorrow. Well, good luck with that.
Yeah, I feel that too. Thank you so much, Rose.
You're welcome. Bye.